that today's conference is being recorded. If you require any further assistance, please press star zero. Thank you. I would now like to hand the conference over to your first speaker today, Ms. April Hamilton. Please go ahead, ma'am.
Thank you, Patricia. Good morning, everybody. My name is April Hamilton, and I'll be your host this morning. Thank you for joining us today, and welcome to the New York State Department of Health webinar regarding telehealth services during the COVID-19 emergency. I apologize for the delay, but we have many participants this morning, and we wanted to give as many people as possible a chance to join. This webinar will review Medicaid guidance issued by the New York State Medicaid program for the COVID-19 emergency, which was issued at the end of March and recently updated with additional clarifications last week. This guidance is available on the Department of Health COVID-19 website for Medicaid providers, along with a frequently asked questions document. As Patricia mentioned, a recording of this webinar will be made available on the same page that the guidance is posted. Greg Allen, the Director of the Division of Program Development and Management at the Office of Health Insurance Programs, will be your presenter today. But first, I'd just like to take care of a few housekeeping items. As this slide shows, there is no sound available through the computer, so participants must dial in through the 1855 number shown on the screen. On the next slide, if we could just go to the next slide, thank you. As you're logging into the webinar, if you see a Cisco WebEx error message that the webinar has reached maximum capacity, you should take a look at an email that you might have received with the subject Webinar Update, New York State Medicaid Guidance Regarding Telehealth, including Telephonic services during the COVID-19 emergency, and click on the second link in that email in order to log in. Okay, just a couple more housekeeping items. There is no sound through the computer, as I said, so if you can hear me, you've dialed in correctly. If you have questions, you can submit those questions through the Q&A function in the WebEx control panel. All participants will be muted throughout the program today. But please feel free to submit your questions throughout the webinar, and our panelists will answer as many questions as possible at the end of the presentation. We'll also be capturing the questions submitted through the Q&A function to ensure that we provide responses to those we don't get to today. And once again, I'd just like to mention that a recording of the webinar will be made available at the Department of Health COVID-19 webpage for Medicaid providers. And with that, I'll turn it over to Greg Allen. Greg?
Thank you very much, April. Good morning, everyone. And first, let me start off with a hearty thank you for all of you who have been out there working the front lines in all of the various forms that the front line has taken throughout this extraordinary time. I want to thank you for your service directly to patients, for your services helping to support those who are serving patients, and for being creative and designing solutions in an unprecedented situation. We are deeply appreciative for all the hard work, patience, and perseverance that has gone on for patients across the state of New York and across the country, and very particularly for those of you who have been trying hard to help the most vulnerable citizens in our state, the Medicaid patients and uninsured patients. The goal today really is to try to address as many technical issues with regard to our changed policies with respect to telehealth services, with a very specific focus on telephonic services, because that is where the major pivot has happened here in terms of service delivery across the state. So you will see in the slides that will come up a great deal of focus on carrying out telehealth services through telephonic means, and the way that we will execute payment to providers for those services. We will also highlight telehealth services as well, but we really are going to focus most specifically on Telephonic as we go through here today. I also just want to start out with a hearty thank you for our team for getting us to this point. Many individuals were involved in the development of this guidance and trying to keep track of all of the issues that providers were having and iterating on guidance as we went forward to try to provide the best coverage for services in this unprecedented situation. So a hearty thank you to the team from across OHIP, those who will be on today, as well as many who assisted behind the scenes. And thank you to all of the providers who've been asking questions that have helped us to shape, the guidance as it's going to be presented today. We do continue to iterate, so I would ask everybody to stay tuned to our website as we try to execute changes here as necessary as the situation evolves. But starting off here with the executive order, which really lays the foundation for all this work in response to the COVID-19 pandemic, Governor Cuomo has issued several executive orders, and we provide the link here to those. And one of those was directing insurance, including Medicaid, to more broadly cover telehealth services. So the telehealth guidance we're going to go through here starts for dates of service on or after March 1st, and it'll remain in effect for the disaster emergency or until we issue subsequent guidance. And again, subsequent guidance could come out as potentially there's some kind of phasing with regard to beginning to open up more face-to-face services in some regions over others. So we will evolve as the situation evolves, so please stay with us and stay tuned. So New York State Medicaid will reimburse telephonic services, and we will provide telephonic reimbursement in cases where face-to-face visits may not be recommended. And there are many, many situations now during the period of emergency where it just is not appropriate to do face-to-face, and telehealth services are not possible. But we also, continue to issue this caution. The service has to be appropriate to be done by telephone. So services that are medically imprudent to do by telephone should be carried out through telehealth, or a face-to-face visit has to be carried out. But many, many services qualify, and we will go through many examples during the period of this webinar. This applies really broadly to any qualified practitioner or service provider that's currently enrolled to serve Medicaid members, and we'll look specifically at those who may be billing separately as practitioners or those who are working in congregate settings like our clinics. When providing services under this guidance, where possible, audiovisual services are the preferred route. Additional information is always available through the audiovisual route, both on the medical and behavioral health side. But so our guidance suggests that telephonic should only be used when audiovisual services are not possible. And then just a reminder that all other requirements, unless they were specifically waived, and we have, been waiving face-to-face requirements for assessments, et cetera, and other things in our applicable policy statements, and April will go through where to find those at the end of the webinar. But unless there's a specific waiver, and we've been receiving lots of requests for waivers, and we have issued many of them, there's also some federal rules that have been waived as well. But unless specifically waived, the regular service provision rules still apply. So this is really a reminder, but even before the public health emergency, we were really well positioned here we had a nice bedrock upon which to execute telehealth services, because we had already broadly expanded telehealth services in Medicaid, including liberalizing services and making them more aligned with the national move to a broader base of telehealth. So we've expanded telehealth originating in distance sites. We began to recognize the member residence as a place where they could be located to receive service, also known as a distance site. We permitted additional telehealth application, including store and forward technology and remote patient monitoring, and we'll go through those in a few slides. We also, and this was very important, had previously expanded to additional practitioner types, and there are some that are listed here on the slide, but we also had a law passed that allows, the commissioners of DOH, OMH, OASIS, OPWDD to even add additional practitioner types as deemed prudent. So before the emergency, we had a really good head start here. However, one of the gaps here was telephonic services, and so we issued emergency telehealth guidance that allows providers to bill Medicaid that can be appropriately delivered by various means during the COVID-19 emergency. This establishes some new payment pathways for all Medicaid providers, including those that are contracted with managed care plans. And again, we have our managed care colleagues on the phone today. But it allowed us to create a pathway to bill for telephonic encounters, and we'll go through how those will work. These are also laid out in our guidance, where April will show us where that's located. We've got a policy document that's out there that goes through what we're going to talk about on the phone today. And there's also a very long and detailed set of frequently asked questions on the same website, and we'd encourage you to take a look at that. It's broken down by provider business area, so it's very easy to navigate and will, I think, help with understanding what's in the policy document. We also, importantly, during this emergency guidance, we relaxed rules on distant and originating site. We'll go through those, and the types of clinicians, facilities, and services that are eligible during this period under telehealth. And again, a lot of the flexibilities have been primarily extended on telephonic, where we did not have those services authorized before. It also allows for the use of any telehealth technology that's non-public facing. Some familiar ones are Skype and FaceTime, with appropriate patient authorization. And we'll talk a little bit more about some flexibilities extended on patient authorization as well. So here we are on that. So this is an important piece. The Department of Health and Human Services, the federal department in their Office for Civil Rights, issued a very important notice of enforcement discretion regarding telehealth during the emergency, and allows the covered health care providers to communicate with patients and provide services through remote communications and not have to be fully complying with all the HIPAA requirements. And again, understanding that things like written consent to services, et cetera, are extremely difficult during the current state of emergency, where members are at home and many providers are practicing from home. But there is an important link here that all providers should be paying attention to, which kind of goes through this good faith provision. There are some additional standards and rules that providers who are operating under regulations for OPWDD, OMH, and OASIS should refer to, and we provide links at the end of the webinar to that guidance. And by the way, we will post this webinar, including the links that are here, afterward. So please don't be busily copying down dots and slashes and trying to get these links. We will provide this. We'll post this as soon as possible after the webinar concludes. Okay, this slide's important because here, especially it extends to telephonic, but most of what we've done on the facilitating additional telehealth flexibility is right here in the originating site and distant site. And this sometimes can get confusing for me to remember what's the originating site and distant site. I think in old parlance we had hub and spoke, but the originating site is where the member is located, and the distant site is where the provider is located generally. Provider sometimes gets confusing in consulting situations where a member may be in a primary care and a consulting, say, neurologist may be providing services. But originating sites where the member is sitting. And during the state of emergency, even for telephonic, you can deliver services to anywhere the member's located and include the member's home. And again, we would ask that some amount of discretion be used here in terms of making sure that privacy can be maintained to the full extent that is possible during these encounters. But there are no limits on the originating sites during the state of the emergency, other than that discretion. And then the distant site is where the telehealth provider is located. And during the state of emergency, this can be anywhere within the 50 United States or our territories. And any of these places are eligible to be a distant site for delivery and payment purposes. And this extends to federally qualified health centers. There were some federal guidelines around and some limits on distant sites for federally qualified health centers, but FQHCs can be both originating and distant sites during the period of the emergency, and there's very specific written guidance. And importantly, the distant site can be the provider's home, and this has become a very ubiquitous circumstance where the member is at home, the provider is at home, the provider may be working either out of a provider office or a provider clinic, but due to the emergency, they are practicing from home, and that is allowable. And that would include where Medicaid may be paying secondary to somebody that's dually eligible for Medicaid and Medicare. So let's get into some definitions quickly if we could. Telemedicine is two-way electronic audio and visual communication, and here's where we're delivering healthcare to a patient at an originating site by a telehealth provider who's located at a distant site, and this can include teledentistry. So the example we use here is we're using FaceTime or Skype, and we're assessing the patient for a new medical condition. Or we're monitoring a problem the patient had previously, like hypertension. And then separately, store and forward, this involves asynchronous, which is kind of a fancy technical term for not at the same time, electronic transmission of members' health information. And this can be in the form of like pre-recorded videos, digital images, and the example we're using here is the primary care provider taking a picture of a tricky skin lesion and then forwarding out to a dermatologist for assessment. And as we mentioned before, Medicaid has expanded to include store and forward technology in our covered definitions. Remote patient monitoring, this uses digital technologies to collect medical data. So the example we use here is a patient's at home, often not able to travel. They might have type 2 diabetes in this example, and the physician and extending practitioners are monitoring their case remotely through this. And then we extend to telephonic. This is what we've been talking about. We're using two-way audio-only communications, generally over telephone, to deliver services to a patient, again, at an originating site by a telehealth provider located at a distant site. And in this example, we're using a patient getting psychotherapy from a psychologist or psychiatrist. And in the cases that we will cover, the member can be at home and the practitioner can be at home as well, and we would cover that telephonic visit. So managed care plans, we have a lot of questions that have been coming in on coverage by the Medicaid managed care plan. Some of the plans had policies prior to the emergency that were concerning to some of the providers, especially where plans may have been utilizing a very specific network of telehealth providers for the provision of telehealth services. And so what we're requiring of the plans is they have to follow the fee-for-service telehealth billing policy that was issued in our Medicaid special update, which we'll link to at the end here, and all of our subsequent updates. But they can follow separate reimbursement, and we'll talk about that on the next slide. So they have to cover telehealth and telephonic delivery of all of the benefit package services that are appropriate to deliver through these means, and they're required to do that to properly care for the member. So they can't execute anything that would get in the way of member access to a covered benefit package if that covered benefit package service can be delivered through telehealth or telephonic means. They can't limit access to the telephonic or telehealth services just to an exclusive planned telehealth vendor. They have to allow, for instance, the patient's primary care provider to deliver routine follow-up care or care for new patients through telehealth and telephonic means. So all of their network providers have to be able to deliver services to patients as appropriate through telehealth and telephonic means. And on the payment side, we're going to go through some detailed fee-for-service billing guidance here, which many of the plans may choose to just directly replicate for telephonic, but some of them have even some national standard coding schemas that they follow, and they can do that. So you may have some plans requiring separate detailed billing guidance, and you should follow the billing guidance from those plans. As time goes on here, we will certainly look to standardize as best we can some of this, but we are all, moving really quickly here to make sure that we can cover. And we want to be able to report this and pay it as quickly as possible. The managed care plans must establish payment pathways for telephonic, which can mirror the 6 payment pathways we're going to talk about in a minute, but they're not required to use those as long as they create a payment pathway for all of the provider types and the services that we'll talk about shortly. And then absent some negotiated rates that already exist, already contracted rates for telehealth and telephonic services, they have to reimburse the network provider at the same rate that would have been paid for face-to-face. However, just to remind everybody, new negotiated rates are possible, so the plan can negotiate rates now for these services with providers. And then questions regarding, reimbursement, documentation requirements should be directed to the member's plan as usual. Okay, so let's jump into telephonic reimbursement. Now, these charts have a lot of detail on them, but we're going to break them down on the subsequent slides. So I will go quickly through the chart, but we will come back in subsequent slides to each of these lanes in detail. We'll provide examples of them. There is quite a bit of detail. This exists in the existing guidance that is out on the website, so this won't be your last look at this. So I'm going to go a little quickly here, but we're going to hit this over and over again through the slides. So the first 2 lanes up are our office-based practitioner billing lanes. And the first one is for those practitioners that can bill evaluation and management services now on the Medicaid fee-for-service fee schedule. And again, these are fee-for-service billing lanes. They may be replicated by the managed care plans. They're certainly available for providers to discuss with the managed care plans if they don't have an existing arrangement for telephonic payment. But in lane 1, we have the E&M providers, the doctors, nurse practitioners, physician assistants, midwives, dentists, and RNs. They're generally paid a fee on the Medicaid fee schedule, and they're usually practicing in the office. We list the rate codes and procedures here in the next column, and there's some specific to RNs and dentists. POS is place of service, and that place of service here should reflect on the claim the location where the service would have been provided face-to-face. And now these modifiers that are going to come up, and we're not going to get deep into modifiers, but the modifiers by many payers and many state Medicaid programs are being used flexibly here. So For those of you who are coding senseis, you'll sometimes notice that we'll be using GQ where it's not exactly what GQ was designed for. And again, we're often using these for tracking purposes during the emergency. So the only time you have to use the GQ modifier is on that 99211, and that's the RN on staff with the doctor. This can be used for new or established patients, and again, the codes here, the procedure codes that we're listing may sometimes for telehealth supposed to only be used for established patients, but those kind of rules are being waived during the period of the emergency, and we make specific reference to this in guidance. And then the 99211 is for the RN who is working out of the practitioner's office. Lane 2 is similar to Lane 1 in that it's for generally licensed folks, but people that bill the fee schedule but are not qualified to do evaluation and management services. So the example used here is the psychologist. And here, any existing procedure code that would have been appropriate for face-to-face service previously that could now be done by telephone, and we'll use some examples later that will kind of give some light to this. Again, the place of service should reflect where the service would have been provided face-to-face. So if that would have been the office, just reflect that location. And again, member can be at home, provider can be at home, but we're gonna follow place of service coding as it would have been before. In this case, we will append the GQ modifier, and this is billable by Medicaid enrolled providers for both new and established patients. Okay, so the next lanes 3 through 6, we're moving out of that fee-based doc practitioner's office world, and we're moving into the congregate world, mostly of clinic, day programs, et cetera, who are trying to reach out to patients during the emergency. So lane 3 here is for off-site evaluation and management services. This is not for FQHCs. There's a special lane for FQHC, docs, nurse practitioners, PAs, midwives, and social workers, which will come up next. But lane 3 is for the non-FQHC clinics primarily. Can also be used by some other providers who are doing rate-based services and billing docs, nurse practitioners, physician assistants, and midwives. You see the rate codes here, and you see the example procedure codes, but really you're just supposed to report the appropriate procedure code for the service. Place of service is not applicable on a clinic claim, but the service location should be the usual zip +4 that would describe where it historically would have taken place. So if you're out in an extension clinic in an existing address, and that's where you as the doctor usually practice from, that is the location code that you should put on the claim. This again is for new and established patients, and this is an all-inclusive payment. These rate codes that we've put up for these services are all-inclusive. We don't expect to see a separate professional claim on top of, essentially this clinic claim. All right, now moving to lane 4 again. We're going to go back over these. I know it's busy and there's a lot here, but lane 4 is for FQHCs, and this is for the licensed practitioner services. And FQHC had existing off-site payments, and those are the rate codes that will be executed here. And by the way, I should have mentioned that anything that's in bold here are the recent changes from our original table that we put up in original guidance. So as we iterate the guidance, when we put a new version up, we bold the new text. And sometimes it's just like wording changes. Sometimes it's actually a change in policy. Here in the FQHC lane, we definitely have iterated the policy here, both on the payment and the payment of the wrap. So all of the FQHC's licensed providers will bill in lane 4, generally under this 4012 non-school-based health center FQHC offsite visit rate code. So this, again, is the docs, the nurse practitioners, PAs, and midwives, but it also includes other licensed practitioners like social workers and psychologists who have historically billed those offsite rate codes for the FQHCs. And again, we clarify over here in the notes that wrap payments are available for these services That was a change from the last time this guidance was issued. So when the service is delivered through managed care, there will be a fee-for-service wraparound payment executed. These services are eligible for that. Lane 5, this is for assessment and patient management for other practitioners who, again, this is for rate-based providers, and this includes clinics and then the non-licensed practitioners that were not in the list in Lane 4 for the FQHC. So it's non-FQHC clinics or the non-docs, non-PAs, et cetera. So these are people not doing evaluation and management but providing, similar services to the folks that were in Lane 2. And here's where FQHCs would bill their non-licensed practitioners. But this can also be utilized by day programs, adult day health care programs, home care providers. And these are new time-based rate codes. And these rate codes are designed to somewhat mirror our Medicaid payments for the practitioner services. They, range from around $12.56, I think, to $37.41. And these rates would be put up on eMedNey, and they'll be available for providers to see. But they're time-based, so each rate code is attached to a time period, just like an evaluation and management service would be. Again, place of services as it would have been on the regular claim. Procedure code and modifier is not required, but procedure codes for per correct claiming process should be put on the claim as appropriate. So whatever the services you're delivering and whatever the best code is, that should be on the claim. However, there's not an edit fail for that particular rate-based payment for this provider. So these are broadly billable by a wide range of providers that would not qualify for payment under evaluation and management. Again, new and established patients, and the NPI of the supervising doc should be listed as the attending, again, as you would on other claims. And then in Lane 6, that's really our catch-all lane for everything else that would not be billable under any of the preceding 5 lanes. So it's not something that would be billed under our practitioner fee schedule. It's not a practitioner who would be executing under one of the time-based rate codes up above. And we've given you guidance like we have for the LICSs and CHAs and the RN visits and assessments. We've given you guidance that Lane 6 is really the appropriate place to bill. And again, we'll go through this in future slides, but this can be used by HCBS providers, peer providers, health homes that are doing their carrying out their member care plan functions, and instead of doing face-to-face, they're doing phone calls. This is where that would get billed. Usually there's some kind of minimum contact requirements that each program area has issued that would make you eligible to bill this. If, for instance, we're paying a monthly rate, for instance, on AIDS adult day program, there's a minimum number of contacts and meals, et cetera, that are required in order to bill this. So you're billing Lane 6 generally because you have guidance from a relevant program area that this is the appropriate lane to bill. There's usually some form of minimum standard, and most of those providers are listed in the EG that's in the table here. All right. So that should make the rest of this kind of fast because it really is a review. And just quickly to review, and this is in the guidance when you go back to look at the guidance, lanes 1 and 2 are used for fee schedule billers. These are usually the practitioners that are working out of office-based settings. And they should bill the fee schedule directly for telephones using the guidance in Lane 1 and Lane 2. And again, we'll provide the link to where all of this exists, and the slide deck will be available. Lanes 3 through 6 are for all the rate-based billers that are usually filling out institutional claim forms, not professional claim forms, and they are billing rates. And they will bill in the lanes as directed. And we'll go through each of these more. We'll speed up here, but we're gonna review. So Lane 1, practitioner E&Ms for the providers that can do E&Ms. Lane 2, practitioner office assessment patient management for those practitioners that have been billing the fee schedule but are not E&M type practitioners, and they're listed. Lane 3, primarily the non-FQHC clinics for the evaluation and management providers, docs, nurse practitioners, et cetera. Lane 4 is for the FQHC practitioners, the licensed practitioners that have been historically billing those off-site rates, that 40-12 rate. Lane 5 is for all the rest of the clinic assessment and patient management. Again, similar to Lane 2 for the office-based, these are the non-evaluation and management practitioners who are billing time-based rate codes for telephonic services. And then Lane 6 is everything else that didn't fit into one of the previous lanes. And that guidance continues to evolve. So, keep close to your program contacts for that guidance. Some of that guidance is out. Some of it is not, but most of it has come out so far. And I think we're saying just roughly, and this may come up in another slide, that we think like 90 to 95% of the billing's happening here within lanes 1 through 5. Lane 6 is really kind of the outlier, services. So clinics, you're going to bill in lanes 3, 4, and 5, depending on whether you're an FQHC and what kind of practitioner you are. Lane 5 is just for the clinics and other programs for the practitioners that don't bill E&Ms. Lane 6 is for everything else. And then again, we're going to issue more guidance on Lane 6 as time goes on. But some of you are already holding guidance that says, hey, you're a Lane 6 biller, which means you bill your existing rates, usually under some kind of modified standard under revised guidance for the period of the emergency. Right. So Lane 1, and this just reviews it all. I'm not going to spend a lot of time, but these slides will be available for everybody. It's got it in kind of a cascade bulleted form, and we're going to get quickly into some examples here. So here's an example of Lane 1. So patient of an office-based physician, nurse practitioner, or physician assistant has diabetes, notes an elevated finger stick, their glucose readings are high, and calls the provider. The provider's in their office, or they could be at home, and they're able to speak to the patient over the phone, review the finger stick readings, the current medications and other patient conditions, adjust the insulin dosing, calls, say 17 minutes, and they will bill according to the following 2 bullets. So here's another Lane 1 example. Patient calls the provider complaining of COVID-like symptoms. They've got a temperature. They have other symptoms. The registered nurse is in the office, or he or she could be home, and they're able to speak to the patient. Patient is screened for possible referral for testing. The RN refers the patient for testing and then provides follow-up guidance as appropriate. And again, the following 2 bullets are technical information on how that would bill. And in the case that it's a registered nurse, it's that 99211 and appending the GQ modifier per the table. Again, Lane 1, the patient calls their dentist complaining of a toothache. Dentist is, say, at home and is able to speak to the patient. It can address the toothache, sends in a script, and then will later schedule a time to see the patient in the office, again, depending on severity, et cetera. Lane 2, and again, our example here is the psychologist not billing evaluation and management, but billing the fee schedule. The example is a patient here might call their physical therapist to discuss pain management and whether their exercise or therapy regime needs to be modified. Physical therapist is able to offer that counsel and then bill the appropriate codes. And again, here is where, an example of where, if possible, telehealth through audio-visual can be very helpful. So if available, should be executed. All right, slide. Lane 3, off-site evaluation management. This is our non-FQHC. This per the setting that we went through before. And here in our example for lane 3, the doc's at home, the patient's at home. So the patient calls, let's say the nurse practitioner, they're in the clinic, they're able to speak to the patient, and they can refer a patient with COVID-like symptoms for testing. And again, in the second example, the practitioner's at home, the patient's at home, they complain of muscle soreness after working in the garden over the weekend. I can actually relate to this one. The call is forwarded to the practitioner, who's currently at home, but affiliated with a clinic, can speak with the patient over the telephone, do assessment, offer a script, and then would bill accordingly. So same thing for FQHCs. They're billing their licensed folks in lane 4. And here we have an example of the nurse practitioner or physician assistant doing follow-up after recent blood work. In lane 4 also, we have a social worker or other licensed practitioner who had historically been, capable of billing those off-site visits, and they do their regular biweekly appointment in lieu of face-to-face by the telephone and then bill accordingly. Again, assessment and patient management here. Lane 5, these are for the other practitioners, again, not billing in the previous lanes. This is for the non-licensed FQHCs as well as all the other practitioners noted. And here are the rate codes and the time-based rate codes. And again, those rates for those services will be up on eMedNy. This lane 5 is broadly billable by a wide range of non-evaluation and management providers. And again, for all of these, it could be a new or established patient. And we just give a few examples here. Again, patient referred to the LCSW for counseling, and both are at home. And there's an example of what would be billed. And here's another example of this lane. This time, the diabetic patient referred to dietitian. Dietitian can be at home, patient can be at home, and would bill accordingly. Here's a non-FQHC dentist example as well in lane 5. And then lane 6, this is the catch-all, all other providers that are not eligible to bill. Again, they're billing their usual rates for the usual fee-for-service rates. And the examples that we give here, again, are home care, adult day health, health home, HCBS, peer services. They would bill their existing rate codes as long as the service could work via telephone. And this would cover everything that was not really covered in lanes 1 through 5. And usually there's other guidance. And we give a couple of examples. In the first example, the Elixir-CHA assessment's done by an RN at the home care agency. It's conducted telephonically while the member's at home. And then it would be billed by the agency under existing rate codes, as if it had been done face-to-face. And then there's another example where targeted case management payment under Nurse Family Partnership is done, and they would bill the usual rate code for that service. So in this lane 6, you're still billing the way you did, but you're billing during the period of emergency for a telephonic service that usually would have been done face-to-face. And then just an important reminder, there may be some minimum standard guidance that's been issued by the relevant program area to follow in the case in lane 6. So one of the questions we keep getting is, are you going to continue to pay for these telephonic services after the period of the emergency? What happens if certain regions have social distancing restrictions lifted sooner? Are you going to mandate a return to face-to-face? None of those questions have been answered yet. We are, carefully following the situation as it evolves. We could make adjustments to this policy, to meet the developing needs of each region, but those decisions have not been made. They will be communicated when they are made. Right now, we are staying the course. We are paying for telehealth services broadly under the expanded distance site and originating site. We are covering these telephonic services. And whenever they're clinically indicated, you should be delivering and billing us appropriately for those services. And we will issue new policy as the situation develops. But again, a lot of these are clinical decisions, right? They rest with the clinician as to whether or not the risk-reward profile for the service face-to-face versus telephonic versus telehealth is appropriate. If a patient needs to be seen face-to-face, then all of you have been figuring out how to get that done and how to get that done as safely as possible for each patient depending on the setting. We would continue to expect that to occur. We would expect this clinical decision-making to evolve over time, and over time as necessary and appropriate, more face-to-face visits may begin to replace telehealth and telephonic visits. That said, we are also, I think, one of the silver linings in all of this is that we are really learning more about how to use telehealth appropriately to extend the reach, especially to some of our, higher risk patients as an alternative to face-to-face. And some of this capacity that's been built will continue to be leveraged, and we would expect that some face-to-face visits would meaningfully migrate to telehealth services over the period, and that may be completely clinically appropriate, which is why we had, broadened telehealth guidance quite a bit even before the emergency. So with that, I will pass the baton back over to my colleague, April Hamilton, to bring us home and then get us into the Q&A. I really appreciate everybody's patience. I know that was a lot of material to cover, and thank you so much for your forbearance. April?
Thanks, Greg. So we just wanted to share a few important links with all of you so that you have additional information available to you. In this slide, there are some state agency partner guidance links. These are links available on the Office of Mental Health website, the Office of Addiction Services and Support, OCFS, and OPWDD. So those state agencies have issued separate guidance which complements the Medicaid guidance and also provides additional information for providers specific to those service areas. On the next slide, there are some important links regarding the Medicare guidance. So CMS has continuously updated their telehealth and telephonic guidance during the emergency regarding services available to Medicare beneficiaries. There is provider-specific guidance on their website, guidance regarding originating and distant sites, and as I said, telephonic services. There is information there regarding crossover billing rules for dual eligible members. And all of that is available on the CMS website if you go to the link identified here. But it is, as I said, frequently updated, so you should check back often for new guidance or sign up for their automatic notifications. Here's some direct links to a couple of important documents issued by CMS. They've issued, as I said before, provider-specific fact sheets for all different provider types, which are very useful and detailed. And on the following slide, we have a couple of important links on the Department of Health website. The first link here is the guidance for Medicaid providers regarding COVID-19. This is where the Medicaid update has been posted regarding telehealth and telephonic services, along with the companion frequently asked questions document. This is the link where we will also post the recording for this webinar and the slide deck. And then importantly, the department is also maintaining a website regarding COVID emergency response for all providers, and the link is provided here. And then I think we are ready to move on to our question and answer session. So we've received tons of questions through the chat box. Through the Q&A. I'm going to share those with our panelists here who are listed here. So we have Jonathan Bick, the Director of the Division of Health Plan Contracting and Oversight, Lana Earl from the Division of Long-Term Care, Alda, Dr. Osagnaga from the Division of Medical and Dental Directors, our telehealth policy expert, Ron Bass, from the Division of Program Development and Management, and Greg will also help answer some questions. So I am going to share questions momentarily. We have several questions regarding FQHCs. Bear with me for a second, please. Greg, will you handle the questions regarding the federally qualified health centers?
Sure, I could take a shot, and then Ron or Alda can help me out if I swing and miss here.
Great. So there are a few questions regarding the specific rate codes that an FQHC should use. The first one is, can you please clarify what rate codes an FQHC should use for a licensed clinical social worker, an optometrist, a physical therapist, or a podiatrist? Is it 4012 or 7963 series?
Yeah, so that answer depends, and Ron will check me here, but that answer really depends on what kind of practitioner it is. So if we go back up here, we'll just, because it might help us here, I think we might get a lot of questions here on the chart. So let me just grab the chart back here. So in lane 4 here, we have the licensed practitioners who are billing the 4012. So rate code 4012 is for physicians, nurse practitioners, PA, midwives, and other licensed practitioners who have historically billed those off-site rate codes. And the two that we know that are probably most prominent are social workers and psychologists. If you're not one of those practitioners that has historically been billing that 4012 for off-site services under an FQHC, then you would be billing under this lane 5 for other practitioners. And again, that would include everybody that's not currently up under that licensed practitioner in lane 4.
Okay, thank you. Guidance states that, I'm sorry, it doesn't say which kind of provider, that a provider can bill the APG rate if the distance site is the provider's home. Is the reimbursement rate the same as if the provider is in an Article 28 facility?
Well, that question's a little tough because I'm not sure if it's really separating out telephonic from audiovisual telehealth. It sounded as if it was a telehealth question, and if so, then our guidance is pretty clear on where the APG should be billed for telehealth, and I would refer the person back to guidance, but in generally it would be the prevailing clinic payment for the FQHC that would apply for the service that was delivered via telehealth. So if the members at home and the providers at home and their clinic is an APG biller and they're doing audiovisual telehealth, they would bill an APG the way they normally would, but with the appropriate appended telehealth modifiers, and they would receive the customary payment as appropriate. And again, Ron, just correct if I said anything wrong there, or Alda.
Yeah, no, Greg, you're correct. And also, you would add the Q3014 code to the admin component for the audiovisual telemedicine.
And that's all laid out in technical detail in the guidance, and it's also re-referenced in the FAQs as well. Thank you, Ron.
Okay. So we have a few questions regarding managed care, which I will call on Jonathan Dick to help us out with.
Hi, good morning, April.
Good morning, Jonathan. Thank you for joining us. I forwarded you the few questions regarding managed care plans.
So, yes, there's a couple of questions I think I can address. I think, well, one of them was, are MCOs allowed to roll reimbursement for telephone visits on their regular monthly capitation payment? So I will take this to mean that the provider has a capitation arrangement with the plan, and so typically those visits, whether they were telephone visits or face-to-face, would be part part of that arrangement. So typically, I would think that would be a part of that capitation arrangement with the plan that the provider has, unless this contract specifically, delineates or separates that apart from the arrangement of the provider. We had another question regarding authorized services. So it appears there may be a case where it's maybe some of the specifically MLTC plans may have stopped authorizations at the same time while negotiating new amendments for rate changes for telehealth. So I think that's an intersection between existing authorizations and contract negotiations. So I would ask that we get a little bit more specifics from the questioner on that, and we can look into that a little bit more deeper. We send it to myself or Lana Earl, and we can ask you for a little bit more details on that. So another question is the effective date for the telehealth, what they're being regarded as the telehealth billing period of March 1st. So the policies that the Medicaid program has adopted for the adoption expansion of telehealth during the emergency, those would be the same date. Effective date for the Medicaid program and Medicaid, including the Medicaid managed care plan. So, again, plans can negotiate different fees, and they can have different billing rules, but the coverage of the expanded telehealth services begins with the coverage for the Medicaid program as a whole.
Okay. Thank you, Jonathan. Dr. Osanaga, can I ask you to take a look at the questions that I referred to you regarding general billing questions and guidance on types of providers and the locations from which telehealth services can be delivered and received?
Yes. Hi, everybody. And Ron, I'm going to ask that you say if I've got this correct. We've gotten questions about the provider, who would be the distant site provider, can be located in order to deliver either telephonic services or telemedicine services. And the provider can be anywhere within the 50 United States or the United States territories. There was a question, I think, in general about somebody in Canada. It needs to be, the provider needs any of the 50 states and or a territory, and there is no limit on the originating site, so where the member is during this time of the state of emergency. We also have some questions here, and I think, Ron, these might be in yours as well, but we have questions about physicians in a hospital outpatient department clinic billing. Normally in face-to-face and in telemedicine, that physician would be able, for that visit, the institution would be able to bill an institutional claim, and the physician would be able to drop a professional claim. For telephone calls, it is only one claim that is dropped, and you should be billing through lane 3, not lane 1. So again, if that's a physician practicing in a hospital outpatient department, or the telephonic visit that they deliver, it should be one claim, one bill submission through lane 3. Ron, just want to verify that that is correct.
Yeah, all of that's correct. You got it.
Okay. Yep. And then, right, I think there's other questions as well about clinicians practicing in Article 28 facilities, whether they're billing in Lane 1 or Lane 3. So this is non-FQHC Article 28 clinics. That would be Lane 3. Lane 1 is really for providers practicing in non-clinic sites. So that would be like a private practitioner office. I think that was, in general, the questions I received. Oh, there's also a question. We've got questions about practitioners in Article 31 clinics, and those practitioners in Article 31 clinics should be following the guidance that OMH has issued. And I believe those links were at the end of the slide set. April, I think that covers in general the questions sent to me.
Thank you, Alda. Greg, can I turn it over to you to answer a few more questions about the FQHC billing process?
Absolutely. So a couple more detailed questions that have come in here. And one of them is, been asked a few times, are we billing our regular PPS rate? And that question's gotten asked specifically and non-specifically. So the regular PPS rate would apply for the telehealth services, but for Telephonic, we are covering at the off-site rate payment because the service, we believe, is better equated to the off-site rate payment. So that would be the 4012. And again, that is for most of the FQHCs who have not opted into APGs. For those who have opted into APGs, and you would bill APGs for telehealth. So the other question we got, and I realized in reading the question, where the confusion is in Lane 4. We say FQHC offsite practitioners can include social workers, but then we're listing other practitioners in Lane 5. So the FQHCs are wondering, where are the social workers for FQHCs billing? They're billing in Lane 4. The social worker EG reference in Lane 5 is really for the non-FQHCs. For FQHCs, Lane 5 is reserved only for their non-licensed practitioners, and you'll see in Lane 5 that is bolded to highlight that as a change. So all the licensed folks in the FQHC that historically been eligible to bill at offsite 4012 would continue to do that. The only practitioners in FQHCs that would bill Lane 5 are those that are not licensed or listed up in that Lane 4 example. And then let me see. There's a detail here, Ron. I don't know if you know the answer to this. Can an FQHC use code Q3014 in billing? And again, a little background noise. I'm sure someone's not muted.
No. If they're billing, if it's telephonic, there is no Q3014 that would be billed. If they're billing for audiovisual telemedicine, you're billing the PPS rate. So again, Q3014 isn't billed. It's only Q3014 is the admin component that's reimbursed to APG telemedicine claims.
So it would only be in the case where that FQHC had opted into APGs and was not billing a PPS rate then?
Yeah, that's correct, Greg.
Thank you, Ron.
Thank you, Greg. Were there any other questions that you wanted to address right now on the FQHC?
I think there's another question here. Will the RAP payment apply for duals when Medicare pays first? And I think we have to take that one offline. I mean, the RAP payment policy would be the same as it is now. I'm not clear on how the RAP works when we pay secondary, so I have to take that one back. But I think that completes the FQHC detail questions, April, for now.
Thank you. Ron, could I turn it over to you, please, to handle some of the more detailed billing questions that have come in?
Sure. Yeah, April, I'm not seeing the questions.
Okay.
Well, I'm seeing the questions, but I'm not seeing the specific questions you would like me to take a look at.
Okay. Here's a detailed question. When billing under Lane 5 for a social worker in a school health department, where should the social worker name be on the UB04, and what CPT codes can be billed for Telephonic?
Is this, if it's a school supportive health services program situation, then that would be under Lane 6. Schools, services provided through SSHSP, those telehealth, telephonic services are billed as if the patient was seen face-to-face. So there is no change there. There's no change in the billing requirements or the way that the claim form is completed.
Okay, thank you. For using the POS code, should providers use the POS for their office for both Medicaid fee-for-service and managed care?
For managed care, you would have to check back with the plan, but for fee-for-service, Lane 1 and Lane 2, and those are services provided by private practitioners. The practitioner would report the place of service where they would normally have seen that patient. So if the patient would have been seen in the private office, then the practitioner would report place of service code 11 as an office-based type service. And that's if the practitioner is in the office or if they're home. It's still where the services would normally have been provided face-to-face.
Okay, thank you.
And April, I'm just gonna break in here and say I want to also tell everybody that we will be capturing all of these questions, and many of them have already been addressed in our FAQ document. We're happy to go through them here. But for new questions, and especially those that come in with some frequency, we'll also be looking to update our FAQ document. So be looking for some changes to that FAQ document after this. It'll give us a little bit to group on the questions and the answers, but the ones we answered and those that we are not able to get to in the time allotted will be added to our FAQ document. And we also have been regularly taking in, questions from the outside and adding them to the FAQ. So please know that we will look to document the answers that you're getting today in the FAQ document, especially for those questions that are ubiquitous.
Thanks, Greg. If you would you mind going to the final slide that has some contact information for folks if they have questions after the webinar where they can reach us?
I think I have the capability to do that, so I will.
Thank you. Ron, there are a few other general billing questions here that I think you could help with. What are the permissible CPT codes to use for lanes 5 and 6 with the appropriate rate codes? Is the CPT code 99211 permissible? Ron, are you with us?
Ron, are you on mute?
Yeah, sorry, I was on mute. Yes, providers should report the CPT code that represents the services that they were providing to that individual telephonically. Normally, that would be evaluation and management codes, the 99201 through 99215, and that's for both new and established patients. Lane 5 and Lane 6, there may be situations where the practitioner is providing the service, like a home health aide or other type of individual. There are no CPT codes that represent those services. In that case, no CPT code would be reported on the claim.
Thank you. We've been putting modifier 95 on our non-FQHC services with rate codes, with CPT codes, 99201 through 99215. How will the insurance company know that it's telephonic if there is no modifier?
For telephonic services, modifier 95 is not required. Essentially, you'll be billing. If it's a practitioner-based type service, you're billing either 99441 to 99443. By definition, that identifies the service as it's inherent in the definition of the CPT code itself. That means it's telephonic. If you're billing if it's a 99211 with the GQ, that requires the GQ modifier. That's for the RN. For all the other services that are being billed, it's inherent in the code that's being in the rate. Well, it's inherent in the rate code that's being billed that the service itself is telephonic.
Thank you. Can you please clarify which lane an Article 31 outpatient mental health clinic would be in?
That really needs to be addressed to OMH directly. And again, the guidance is the link is at the end of the slide presentation.
Thank you, Ron. We also
the link's right
have
here, and they've also been doing OMH, Oasis, and the other agencies have also been doing webinars as well, and they've been doing FAQs and guidance. So all of that information is available again at these links here, and this will be provided after we conclude.
Thanks, Greg. We do have a few general questions for you, Greg. The first is someone has noticed that the recent changes to the Medicaid update and the FAQ have been bolded. The question is, are those changes that were made backdated to the beginning of the emergency? For example, the place of service code 02 was added. Will these changes be effective moving forward, or will they be backdated to the original March 1st date?
Yeah, so that question could take many forms. So in general, they apply backdated to the date of the emergency. So for instance, where we are issuing more permissive policy that allows, wrap payments to FQHCs, inclusion of other practitioners in various lanes, those would be all in effect until, back to the original date of emergency. If you're saying that you've already submitted some claims that might have had a different place of service code on them, and do you have to go back and adjust those claims? Ron, I assume that we would appreciate that. I just want to ask if it's actually required if, say, a claim came in on March 2nd with a different understanding on place of service, would that claim still reject, and would it be essential that it be adjusted?
Yeah, if a claim was rejected, I think the claim will have to be resubmitted as
right. But what if it was not rejected because we didn't edit on, for instance, the place of service? It was just they didn't get the place of service guidance until later, and the claim paid. Are we requiring an adjustment to those?
No, we're not.
Okay, so I think the best way, that's what I assumed you'd say. So I think all of where we have made changes that make things more permissive, those permissions are eligible permissions back to the original date of the emergency at the March 1st. But if it is a technical change that we've made on billing description and your claim did pay, we always appreciate adjustments to make them accurate with the guidance. And if you can execute those are appreciated. But if the claim paid, we're not requiring it during the period of emergency to, make that claims adjustment.
Okay, thank you. We are receiving several questions from providers who serve the developmentally disabled population. So I'm going to ask that those questions, we'll certainly capture those questions and work with our state partners at the Office for People with Developmental Disabilities to address those questions in our FAQ document, but I would also refer you to OPWDD to assist with any questions that you might have. Although we do have a question here that perhaps you can answer regarding DME. Can equipment clinic type visits, for example, fitting or evaluating for equipment like a wheelchair, a bed, bathing equipment, or other types of equipment be included in telehealth visits? What are the billing and reporting requirements for doing this?
Hi, April. This is Alda. I'm not sure about the answer to that question, but I know where we can go to find the answer to that, so we'll have to follow up on that question.
Okay, thank you.
April, may I also clarify, we've gotten some subsequent questions after I spoke earlier about physician billing and for audiovisual communication, telemedicine. Can I just make a clarification?
Please.
All right, so when I spoke earlier about telemedicine and audiovisual communication, I said that physicians who work in hospital OPDs can drop a professional claim and an institutional claim, and that's in the guidance. I just want to make sure that that's, again, just physicians in hospital outpatient departments. Physicians practicing in Article 28 DTNCs, that they cannot drop both a professional claim and an institutional claim. This policy has not changed from, prior to the state of emergency. All practitioner types, physicians and all the other practitioner types in DTNCs, the professional part of that component is already included in the APG payment, so it's already included in the institution. The only provider types that can, in Article 28 facilities that can drop a professional claim are physicians in hospital OPDs, and they can continue to do that for audiovisual communication, but they cannot do that for telephone. In telephone, any practitioner in an Article 28 facility, they can only drop a claim in lane 3. I hope that clarifies. I spoke pretty fast there, but hopefully that was clear. And that is in the guidance that is posted now.
Okay. Thank you. There's another question that you may be able to help clarify. Does this guidance cover new patients?
Sorry, I was having
April.
taking myself off mute. Sorry, Ron, go ahead.
Yeah, April, this is Ron. The Telephonic covers both new patients and new as well as established. I mean, we recognize that initially, Medicare was only covering Telephonic in certain circumstances for established patients. They've changed their policy on this, but New York State Medicaid, we were from initially and currently right now, Telephonic is for both new and established patients.
Thank you, Ron.
So this is...
Yes, please, Alda, go ahead.
This is just another thing it looks like people were hoping we could clarify. The billing of codes 99441 to 99443, those CPT codes are specific telephone service calls, and those are the codes that providers in lane 1 we are asking them to bill. So there's been questions about those specific codes and where they should be billed, and we're asking lane 1 providers to do that. And so that lane 1 providers, if you're doing a telephone call, please bill 99441 to 99443 and not an E&M code for those telephone calls. That's again just lane 1 providers. Lane 3 and lane 4 providers, for your telephone calls, you're allowed to bill E&M codes.
Thank you, Alda, excuse me. So I'm just doing a time check here. We're down to 1 minute remaining in the webinar, so I think we could take 1 or 2 more questions. Greg, there are a couple of general questions here available regarding telehealth visits in general.
Sorry, April, do you mind just reading them to me? I'm
Sure. There's a
now
question here.
it's become long here.
Yeah. Is there specific guidance for rural health clinics regarding telehealth? Maybe that's a question for Ron or you.
Yeah, April, this is Ron. Rural health clinics, it would be the same guidance that would apply to FQHCs.
Okay.
Again, assuming they meet that federal definition of the rural, federally designated rural clinic.
Okay. Well, with that,
And April, I'm just going to say one more thing as we wrap here, and that is we appreciate all these questions. We did not get to all of them. I see some places where there's even thematically some long-term care questions, interactions between lanes 5 and 6. We will definitely get back to all of these in writing, but we may also just review this for whether or not there might be sector-specific webinars that we want to follow up on. So we'll also stay tuned, because if we think after looking through these questions that a sector-specific webinars might be useful, we'll use that as another option of addressing them. But we will for sure get back in writing on all of these questions. And I just want to thank all of our panelists and thank April, thank our organizers and our operator today, and end where we started, which is to thank each and every one of you for assisting the state in managing during this crisis. It's heroic efforts, and they're appreciated. And we will get to each of these questions and add them to our FAQ and get that updated as quickly as we can, because we know a lot of you need answers to these questions for operations. So thank you for your patience, your perseverance, and your service. It's very, very much appreciated. So I'll turn it back to you, April, to close.
Thank you, Greg. So as you can see up on the screen right now, if you have additional questions that you didn't submit via the chat box today, you're welcome to send those to our shared mailbox at telehealth.policy@health.ny.gov. And we thank you for joining us today.
Bye-bye, everyone.
Ladies and gentlemen, this concludes today's conference call. Thank you for participating. You may now disconnect.